welcome back to the final explainer in our three-part series on visual-induced dizziness, or VID. Now, over the last two explainers, we've pretty much completely dismantled the idea that patients who get dizzy in supermarkets or while scrolling on their phones are just anxious, right? We built a really solid clinical framework for recognizing that underlying visual-vestibular mismatch. So today, we are bringing it all together into a structured, highly effective clinical pathway. We're talking exact treatments, real-world timelines, and knowing exactly when it's time to refer. Okay, let's dive right into this. Think about this for a second. Which chronic dizziness syndrome responds reliably to a completely free, structured rehabilitation program that your patients can do right in their own homes? The answer, of course, is visual-induced dizziness. The intervention we are about to cover is an absolute game changer. Most of these patients have literally spent months accumulating perfectly normal test results, constantly being told there's nothing structurally wrong with them. But with the specific tools we're going over today, you can actually give them their lives back. So here's our quick roadmap for today's explainer. We're going to hit the 3 management pillars, walk through the 4-phase visual habituation ladder, tackle targeted pharmacotherapy, go over some incredibly useful lifestyle and driving scripts, and finally, lock down your referral triggers and red flags. The best part here? The vast majority of patients with VID can actually be successfully managed right in primary care using this exact approach. All right, kicking things off with Section 1, the 3 management pillars. Successful management of this condition absolutely requires a multi-pronged approach, and it essentially rests on these 3 distinct pillars. Pillar 1 is structured visual habituation. And I really want to be incredibly clear here. This means structured optokinetic provocation. We are not talking about generic vestibular rehab. Generic physical therapy often completely misses the mark for these folks because their issue is visual dependence, not just basic balance. Pillar 2 is parallel treatment of any underlying condition, so stuff like vestibular migraine or PPPD. And Pillar 3 rounds the whole thing out with specific lifestyle modifications and cognitive behavioral therapy. Moving right along to Section 2, 4-phase visual habituation. Now, what's really interesting about this slide is how we use this latter methodology. This is your core intervention to retrain the brain and essentially stop that over-reliance on visual input. It's a very deliberate, sequential progression. Phase 1 is preparation, so that's educating your patient, setting realistic expectations, and getting a baseline visual vertigo analog scale or VVAS score. Phase 2 introduces optokinetic provocation in a tightly controlled way. Phase 3 steps it up to real-world graded exposure. And finally, Phase 4 is maintenance, which means weekly self-exposure, checking that VVAS score every 3 months, and immediately getting back on the ladder if they have a flare-up. By systematically climbing this ladder, we predictably normalize how they integrate sensory info. Let's break down those active phases. Phase 2 is where the actual neuroplasticity happens. You're prescribing optokinetic provocation. Now, this could be watching moving black and white stripes, rotating dot fields, or honestly, even just scrolling a video on a screen. But the parameters are strict. 1 to 2 minute sessions, strictly twice daily. And the golden rule here, symptom intensity must stay at a 2 or 3 out of 10, no higher. We are treating this exactly like exposure therapy. Short, frequent, just slightly uncomfortable doses. You've got to warn your patients that a transient spike in symptoms during that first week is completely expected. If they come back saying, I actually felt a bit worse at first, well, they are probably doing it perfectly. They just need to stick with it. Once they can tolerate those screens without severe symptom spikes, that's when we graduate to Phase 3, real-world graded exposure. And the sequence is super deliberate. You do not send them straight to a chaotic, crowded mall on a Saturday afternoon. You start small, a quiet supermarket aisle, then progress to walking on those busy patterned carpets. Next up, introduce escalators. Finally, you tackle the most visually complex environments, like being a passenger on the highway. It's literally a storyboarded progression from controlled visual noise straight through to chaotic, real-world optic flow. And here is the massive payoff, 50%. Data from Pavlou and colleagues shows that structured optokinetic habituation, literally just climbing the ladder we just went over, cuts VVAS scores by roughly half at 12 weeks when compared to generic vestibular rehab. Half the symptom burden, just from deliberate twice-daily visual exposure. It is absolutely incredible how effective this is. Okay, shifting gears to Section 3, pharmacotherapy and suppressants. Sometimes that habituation needs a pharmacological overlay to truly stick, depending entirely on what the underlying condition is. If the patient has persistent postural perceptual dizziness, or PPPD, SSRIs and SNRIs are your absolute first line. We're looking at sertraline at 25 to 50 milligrams a day, or venlafaxine at 37.5 to 75 milligrams a day. Now, if vestibular migraine is the main driver, you pivot right to standard migraine prophylaxis, propranolol, amitriptyline, or topiramate. But listen, pay close attention to the timeline here. These medications take 8 to 12 weeks to build up to an effective clinical level. You absolutely must explicitly warn the patient about this delay, or I guarantee you they will abandon the medication long before it even has a chance to work. Now, this right here is where management often completely goes off the rails. You absolutely do want to treat those underlying conditions aggressively, but you must avoid prescribing vestibular suppressants at all costs. I'm talking about things like prochlorperazine, betahistine, and benzodiazepines. Just do not prescribe them for chronic visual-induced dizziness. Period. So the crucial point here from the literature is this. Vestibular suppressants actively maintain visual dependence. They literally blunt the brain's ability to undergo central recalibration. When you hand a patient a suppressant, you are pharmacologically undermining the exact neuroplasticity you are trying so hard to create with the habituation ladder. According to the research, they are the single dominant modifiable factor in poor recovery. We have to stop using the suppressants. Next up, Section 4, Lifestyle, Screens, and Driving. Here are some highly practical, rapid-fire scripts you can basically hand directly to your patient today to give them immediate, actionable control over their symptoms. First, screen hygiene is vital. Tell them to limit continuous phone scrolling to 10 to 15-minute blocks tops. Get them on the 20-20-20 rule. Every 20 minutes, look at something 20 feet away for 20 seconds. Advise them to use matte screens instead of glossy ones, and for sure, tell them to bump up their font size. Another strict rule, absolutely zero scrolling on a phone while moving in a vehicle. For driving, familiar low-traffic routes are usually okay for mild to moderate symptoms, but high-speed highway driving? Reintroduce that last. Finally, if avoidance behaviors or panic attacks are really prominent when they face these visual triggers, CBT is a super effective adjunct to keep them engaged in their physical rehab. And finally, Section 5, Referrals and Red Flags. Now, while most of this can be handled beautifully in primary care, you do need an escapement strategy. And this brilliantly illustrates your exact referral triggers. If their VVAS score is over 15 and shows literally no improvement after 6 weeks of structured habituation, or if there's complete habituation failure at 12 weeks, refer them out. If you suspect PPPD but need diagnostic confirmation or complex pharmacotherapy planning, refer. If they've got vestibular migraine that just isn't responding to your standard prophylaxis, or Maladie-Barkman syndrome persisting beyond 3 months, refer. And really importantly, if there is any coexisting hearing loss, diagnostic uncertainty, or a request for a second opinion, they need a specialized audiological and vestibular workup. Having this structured safety net protects you as the primary clinician and makes absolute sure that complex patients don't fall through the cracks. I do want to end the clinical portion of this explainer on a very serious note. These are your absolute, non-negotiable red flags that demand urgent imaging or an immediate acute vestibular review. Vertical nystagmus or direction-changing horizontal nystagmus. Persistent oscillopsia, that's where the patient tells you the world physically bounces when they move their head. Any focal neurology at all, like diplopia or limb weakness. And finally, new or progressive symptoms in an older patient with vascular risk factors. VID is rarely a stroke, but central lesions can absolutely mimic these visual triggers. If you see any of these, act immediately. Well, that concludes our 3-part series on visual-induced dizziness. We've journeyed all the way from recognizing a condition that routine office exams almost always miss, straight through the pathophysiology of visual-vestibular mismatch, and finally today, arming you with the 4-phase habituation ladder, precise pharmacotherapy, and explicit referral triggers. Thank you so much for engaging with this material. To explore more dizziness, vertigo, and imbalanced topics, and to access the 1-page cheat sheets and patient materials that support all of his content, please visit AustralianDizzinessClinics.com. Oh, and please subscribe and leave a rating if you found this helpful. I'm going to leave you with this one final thought. When that patient walks into your clinic tomorrow morning describing a swimming head right in the middle of a supermarket aisle, will you simply reach for reassurance and a standard blood panel, or will you reach for the VVAS, the optokinetic stripes, and the 4-phase habituation ladder? That choice completely changes their trajectory. See you next time.